Is on now. Let's start. Welcome to the third statewide anesthesia critical care seminar. And my name is Dr. Cornelius Sendagiri, and I'm a lecturer at Mackay University, and as well as anesthesia intensive care specialist at the Uganda Heart Institute. So we have 4 speakers today, and they were mentored by Dr. Agava Peter. I will go ahead and hand this over to Dr. Erasmus Okelo, since we are really bad on time, to take this away, and he will introduce the team for today. Please post your questions in the chat room to be responded to by the mentor or the team. And you are all going to be muted, and you have to be able to unmute yourselves until such a point that we have a Q&A. Each speaker will have not more than 20 minutes, and I will be alerting the speakers 5 minutes to the end of their time. So Dr. Erasmus, please take it away. Thank you.
Thank you very much, Dr. Cornelius, and thanks everyone for your patience. We're 20 minutes in, but as usual, just a few opening remarks here. We are good to start. We're on Pulmonary Madness. This is episode number 3. In the previous episode, we handled the hypoxemic respiratory last Friday, mentored by Professor Arthur, and we had a number of presentations relevant to hypoxemic respiratory failure with a number of high-level speakers that day. And we had quite a good take-home regarding hypoxemia and the cardinal representative critical care diagnosis of ARDS driving the points home. And really, at the end of the day, the idea is that you want to keep the lungs dry, clean, and understretched. And when you are administering oxygen therapy, be safe, so that you're not only improving oxygenation in this patient, but also keeping them alive long enough for them to recover and get out of the ICU. So this was recorded and kept in the YouTube channel that you can access. It's clickable. Today is episode number 3, and we shall be looking at aspects to do with breathing out. And really, we're talking about obstructive airways diseases, as we shall probably, the most essential of you might have picked up already. So today's session is mentored by Dr. Peter Agava, and myself and Dr. Cornelius will be the moderators. We have a number of speakers that will, take us through this. Dr. Ignatius Sembuya will present a clinical case, and then Dr. Ivan Kamara will take us to the pathophysiology of obstructive lung diseases. And in this case, our focus really is on the physiology of critical illness. And then Dr. Atunyo will take us through the critical care management of these patients. And finally, going more high-tech will be Dr. Claire taking us through the aspects of extracorporeal respiratory support. So without further ado, we'd like to invite the first speaker, Dr. Ignatius, to share his slides and start us off right away. Thank you.
Good afternoon, everyone. I'm sorry for the mishap that has happened. Hope you can see my slide. Today I'm going to present a case of a COPD, a patient that had COPD, was managed in an ICU in Kampala. She was an 8-year, can you hear me? Okay, so thank you. She's a 68-year-old female who had been living with a COPD, had episodes of easy fatigability, noisy breathing, productive cough with yellow sputum for about a month. And this had worsened for 3 days when she got a nasal congestion and sore throat. She presented to us with episodes of disorientation, and in ICU she got loss of consciousness. That was for 1 day. Disorientation was for 2 days. She had more than 6 admissions in the past 2 months for COPD exacerbations, managed with oxygen nebulizations and IV medications. On examination, she was very sick, in respiratory distress, breathing with pursed lips. She was dehydrated, and febrile with 38 febrile, and she was saturating at 76% room air with prongs. She was at 80, hitting 84%. On examination, she had a barrow chest, Hoover sign, and severe respiratory distress with minimal chest movement. She had that tachypnea of 34, prolonged expiration with a hyperresonant chest, transmitted sounds with coarse crepitations, mostly in the right axilla. On CVS, she had engorged neck veins, warm peripheries. Capillary fill time was prolonged and a tachycardia of 148. She was hypotensive, raised GVP, and a diffuse apex beat, although the heart sounds were audible, although soft. She was agitated, up and about, turning about in the bed. GCS was 11, and she had no focal neurology. At that moment, we had done investigations in the OPD. CBC, she had neutrophilia and a moderate anemia. The ABG showed respiratory acidosis with metabolic alkalosis, and we had an elevation of the creatinine. Electrolytes were okay, albumin was low, but on lower board of the normal. Urinalysis, she had that dark colored turbid urine with pus cells of 20 per high power field and gram-positive cocci on sputum analysis. This came the day after she had been admitted. The chest X-ray, sorry, don't have images, but chest X-ray had heterogeneous opacities in the right lower lung with hyperinflated chest, lung fields with flat diaphragms bilaterally. The POCUS bedside had a dilated right ventricle with a pulmonary trunk with moderate tricuspid regurgitation, and ECG had a P pulmonar and right axis deviation with right ventricular hypertrophy. Brain CT scan was unremarkable. At that moment, we were working with an exacerbation of COPD with pneumonia, respiratory acidosis with metabolic alkalosis, and a UTI. We instituted the management, a PPI, an antiemetic, and we also gave her antibiotics, hydrocortisone as a bolus, and budesonide with epinephrine nebulizations. These were to be given 6 hourly. However, the respiratory rate went down to until 10 breaths per minute. When you instituted the NIV, started pressure synchronized intermittent mandatory ventilation, PSIMV, with FiO2 of 0.6. Those are the other parameters. The respiratory rate was set to 20, and the inspiratory time was 0.8. We wanted longer expiratory time, wanted to allow longer expiration to blow off the carbon dioxide. We achieved about 400 mils of ventilation, and we managed to calm her down with some Fenket infusion. RBPs on the following day, RBPs improved from these values, 8840 to 9852, and the heart rate came down. That is the following morning. She came in the evening. So by morning, the heart rate had come down, the BPs had risen, and she was oxygenating at 86%. We continued with the pressure support, PSIMV, but we started alternating it with the pressure support and achieving these volumes, 300 to 500. NGT feedings were started, continued antibiotics, and Ringer's lactate was also run at 55 mils per hour. She had an AKI, and her urine output she was oliguric, so she was dehydrated, and urine output, fluid balance showed a positive balance. So we worked with some fluids. The BPs on day 3 continued to improve. The ABG also improved, and she was switched to BiPAP, having 4 hours of rest on nasal prongs, the respiratory rate of 22 breaths per minute. And we took off the fentanyl sedation. And on day 4, she continued to improve, much better. And we discharged her to the ward on formaldehyde ipratropium inhalers using a spacer. And this is our discharging ABG. Yeah, thank you very much. And today we are going to have to learn more on what we should have done, what would have been done, what was happening with this patient, why was she having whatever she had. We hope to learn from today's presenters. Thank you very much, moderator.
All right. So just checking with the group, is there any question? We shall take 1 or 2 questions to the presenter regarding the case, and then we shall proceed. Any questions from the audience? Just put up your hand. We'll see you and allow you to unmute. Okay, so there are no questions. We shall proceed to the first presentation. After the second presentation, after this presentation, we shall have a quick poll question for us to get to be interactive with what has been presented. And then we shall go into the third presentation of the day. Dr. Kamara Evans, you're welcome. Thank you for joining in. Please take it away.
Thank you. Good afternoon, everyone. So I'm going to go through the pathophysiology of obstructive lung disease. And obstructive lung disease, as it implies, is a group of conditions that cause obstruction to the flow of air within the lungs, resulting in increased resistance of the airways. So this includes several pathologies, but we are going to mainly concentrate on asthma and COPD for this presentation, because they sort of represent a lot of the pathophysiology that happens in the other conditions. So starting with asthma. Asthma is a chronic inflammatory respiratory condition, and the typical presentation of asthma is intermittent dyspnea. Dyspnea is the main symptom in obstructive airway disease. So asthma patients will present with intermittent dyspnea, cough, and wheezing. And the distinction here with the distinction it has with the other diseases in this category is that the airway obstruction is reversible. So the etiology is genetic, and it's genetic, but some risk factors play into the genetics. So we have certain factors that have been identified that will trigger asthma in the people that are already genetically predisposed. So there's atopy, smoking, viral infections, especially in infancy, prematurity, and maternal diet. So the pathophysiology of asthma has 3 main pathophysiological processes, and that is inflammation of the airways, bronchial hyperresponsiveness, and reversible airway obstruction. So these are interrelated, but this flow chart summarizes what happens when a person comes into contact with the allergen or the antigen, and it's identified by the T helper cells, which trigger the production of IgE, which in turn will lead to release of histamine, prostaglandins, and leukotrienes that will cause smooth muscle contraction and smooth muscle contraction. And along with this process, we have edema of the airways and mucus accumulation in the airways. So like the previous slide talked about, we have smooth muscle contraction, that's the bronchoconstriction. And we have edema of the airways and mucus plug. So here it would help to recall a bit of the relationship between airflow in the lungs, relationship between the airflow and resistance of the airways, which is the first equation, the one on your left, the Poiseuille's law, where you can see a relationship between the airflow in the lungs with the resistance. So a change here, what we are concerned about here in this equation actually is mainly the radius. Sorry, the R stands for radius. That's our main concern here. So the radius of the airways matters when it comes to resistance. So when we have a change in the radius of the airways, it causes a subsequent increase in the resistance of the airways and a reduction in airflow. So in an acute exacerbation, we have increased airway resistance and decreased pulmonary compliance, which leads to an increased work of breathing. So we've already looked at the airway resistance coming from the fact that the airways are now constricted with a smaller radius. And in addition to that, we have decreased pulmonary compliance, which leads to increased work of breathing. And then in addition to that, we have a ventilation perfusion mismatch. Now, if you can visualize the lung and the pulmonary vasculature and the airways, if you have constriction in the bronchioles, then you're going to have some parts of the lung that are poorly ventilated. So inevitably, you're going to have a ventilation perfusion mismatch, and this adds to the problem. In addition, you also have an increased intrapleural pressure, and this affects the venous return. So normally intrapleural pressure is more negative, but is more negative when you're expiring. But in obstructive airway disease, you have an increased intrapleural pressure when you're expiring, and so that makes it harder to expire, and then you have increased venous return. So moving on to COPD, chronic obstructive pulmonary disease. This is also not a specific disease entity, but it's a heterogeneous lung condition characterized by chronic respiratory systems or exacerbations due to changes in the airways. So to note here is that it's chronic and the airway changes are often progressive, unlike with asthma, and they are not reversible. Clinically, they use that to differentiate between COPD and asthma, so that the lung spirometry, which is done in the chest clinics, often looks at the lung volumes, and before they look at the lung volumes before they give a bronchodilator and afterwards. And if obstruction is reversible, then they make a diagnosis of asthma rather than COPD. But COPD has several entities, but the main entities that have been isolated for clinical purposes are emphysema and chronic bronchitis. So the causes and the risk factors of COPD are mainly smoking, air pollution, and there's a genetic component. So there's a genetic predisposition. Most individuals have a genetic predisposition already, and then when these other environmental factors interact with that, then you get COPD. Some of course, there are some that may not have the genes that have been identified, but then they still have maybe long-term exposure to the air pollutants or smoking, and they end up with COPD. So the pathophysiological changes are quite similar, and we have inflammation, remodeling of the airways, and bronchoconstriction. So these processes basically lead to hypoxemia. And this slide is looking at chronic inflammation, which it starts in a similar way where we have noxious stimuli, that is either smoke, cigarette smoke, or an air pollutant. So when they get to the epithelial cells and diffuse into the cells, then the inflammatory mediators are released, and and then you have edema, loss of mucociliary function, and this leads to impaired diffusion and increased airway resistance. So diffusion, as you may recall, diffusion depends, the rate of diffusion or the efficiency of diffusion is going to depend on how thick your membrane is, the distance, and also the surface area available for diffusion. So in an inflammatory process that leads to edema of the airways, you have a greater distance for oxygen to diffuse out of the alveoli into the bloodstream, and you may also have less surface area for diffusion to occur. So all this causes a decrease in the concentration of oxygen in the blood flow, which is hypoxemia. Similarly, we have airway remodeling, also due to inflammation, but now in more of a chronic state. You have changes in the collagen disposition of the airway, then goblet cell hyperplasia. So you have an increased thickness of the reticular basement membrane and increased airway smooth muscle mass. So this similarly leads to narrowing of the airways, increased airway resistance, and in the alveoli in particular, you have air trapping, and air trapping essentially means that the air, you cannot expire all the air that you should have expired. So you develop, so the patient will develop hypercapnia. Bronchoconstriction also is quite similar. You have stimuli causing contraction of the smooth muscles and increased airway resistance, also leading to air trapping and hypercapnia. So these processes, these images are just showing what I've said just in a visual form. So a normal bronchus has a wider lumen, it has a thinner wall, and you have a normal number of mucus glands. This image also is just showing what we have said about the alveoli, where you have airway remodeling, you have narrowing of the airways, remodeling of those airways, and the alveoli becoming hyperinflated because the alveolar wall has also been destroyed and has lost its elasticity. So you have hyperinflation of the alveoli. So to note here on the alveoli is that when they lose their elastic recoil, then expiration cannot occur as it normally should. So in a normal expiration, the pressure in the alveolar pressure should be greater than the atmospheric pressure, more positive. But when the alveoli lose their elastic recoil, they cannot apply that pressure to push the air back out. And that's why you have air trapping and hyperinflation with hypercapnia occurring down the road. So in summary, all the changes lead to hypoxemia, which eventually causes hypoxia. and hypercapnia. So when we come to hypoxia, it has very many effects on lots of the systems, but we are going to look at the regulatory, mainly the regulatory mechanisms. So when we have hypoxemia, the peripheral chemoreceptors will pick it up and cause hyperventilation. Then we'll also have pulmonary vasoconstriction. So unlike other organs where hypoxemia would naturally cause vasodilation in the lungs, hypoxemia causes vasoconstriction. So this, as you can imagine, sort of makes things worse. So you have an increased pulmonary arterial pressure, and this can in turn go back to the right ventricle and cause increased work of the right ventricle. Because if you have narrower pulmonary vessels, arterioles, then the right ventricle has to exert a greater pressure to pump blood to the pulmonary vasculature circulation. So that's one of the considerations in obstructive lung disease. You have to consider the fact that we have that loop going back to the right ventricle. Then we also have renal production of erythropoietin, which is a response to hypoxemia and causes an increase in hemoglobin, which increases the oxygen carrying capacity. This is self-explanatory. This is the body trying to create more hemoglobin, because when there's hypoxemia, the message is that there isn't enough oxygen, and we need to increase the oxygen carrying capacity by increasing hemoglobin. So hypercapnia, on the other hand, is detected by the central chemoreceptors because they are more sensitive to CO2 than they are to oxygen. So when you have CO2 in the bloodstream, increased levels of CO2 in the bloodstream, when they get to the blood-brain barrier, they can cross because they are lipid soluble. And when they cross, then we have when they disintegrate, they ionize into when they cross into the brain, then we have central chemoreceptors in the medulla now responding by causing hyperventilation. So these are just the systemic effects that come about from the processes that we have just seen. The more, maybe the more significant ones: pulmonary hypertension and copulmonary. Pulmonary hypertension, because we have hypoxic vasoconstriction. And then copulmonary, we have right-sided heart failure, secondary to pulmonary hypertension. So that's this image is showing copulmonary, which is really what the other slide has just said. So you have pulmonary vasoconstriction, which gradually leads to increased work of the right ventricle, and you get you may get an enlarged right ventricle. Of course, if it progresses even further, it can lead to left ventricular failure as well. But mainly, we are looking at right ventricular failure. So these are the main pathophysiological processes that bring about the symptoms of obstructive lung disease. So typically they have chronic dyspnea is the main symptom when it comes to obstructive lung disease, and then cough with sputum production. That also explains the treatment that we give, as you saw in the clinical case they presented. We have bronchodilators. We have steroids as the mainstay of treatment, because of the inflammatory, because an inflammatory process is at the core of the pathophysiological process. So we have the patients normally get steroids, inhaled steroids, and then they also, on addition, use bronchodilators and then mucolytics to deal with the cough and sputum. Now, obviously, these patients usually present with comorbidities. So it may not just be simply and clearly COPD. They may have pneumonia as well, interstitial lung disease, CA lung, but the pathophysiological processes are mainly the same. It's recalling that the main issue is we have increased airway resistance, we have narrowing of the airways, loss of elastic recoil of the airways, so we have increased airway resistance and obstruction to the airflow. So that is my presentation in summary. Thank you for listening. Maybe we'll take questions.
All right, thank you very much, Dr. Kamara. Do we have any questions from the audience? Please just put your hand up, and then we'll be able to see you and help you unmute.
Irene Kello Gift has got a question. Kindly unmute and ask. Irene?
Let me see. Irene, you can unmute yourself in case you have a question. Or were you clapping? Sorry, I missed it looked like it was a clapping emoji, something. Okay, it seems there may not be any questions. So what we'll do, I see a question in the chat room. I see a question in the chat room from Dr. Preach. Dr. Preach, would you like to unmute and ask and direct a question to any of the first two speakers or both?
Dr. Preach inboxed me mentioning that he's in flight and
Okay.
he may not be able to participate further. But basically his question is asking for some of the basics in clinical evaluation of patients with COPD exacerbation. Is asking the echo findings were quite significant, suggestive of significant pulmonary hypertension. During physical exam, was a loud P2 picked up? Not to be gregarious, but such findings are very helpful when you don't have echo nearby. Also, it was mentioned that the JVP was elevated. Was sildenafil added to the treatment? In addition to the NIV needed a delta of 6 millimeters of mercury to give good tidal volumes. Was the patient discharged on prophylactic antibiotics to prevent progression of disease? So Ignatius, it's up to you. Ignatius, did you get this information on a review of the patient's file?
Thank you very much, Doctor. Sorry, the first question was about the P2, the loud P2 on heart sounds. Yes, we had that one. The second one was about the sildenafil. They gave sildenafil and bocetan. That one I missed it out, sorry. The other one is, the last question was if we gave antibiotics, is it?
Yes, the question is whether the patient was discharged on prophylactic antibiotics.
So the patient was still on antibiotics by the was discharged late home, sorry, not late home, sent to ward from ICU on antibiotics. I need to follow up and see if they got antibiotics when they were leaving the unit, the hospital.
All right. My follow-up question, I guess, just to expound, since it's a physiology-related conversation. That loud P2, do you have an idea why the P2 is loud in these patients? And what other clinical findings would you expect on auscultation?
Oh, I think it's because of the pressures in that is in the pressures, pulmonary pressures. So the semilunar valves would have to close with a lot of, force coming from the lungs, coming from the pulmonary trunk because of the pulmonary hypertension. So they would give us a very loud sound. That's why it would have the loud P2. Maybe the team could expound more on what else we would find on examination, the palpations of the chest to see what more we can pick next time. Thank you very much.
All right. I'm still interested just in auscultation. So maybe the question will now be to Dr. Kamara regarding the clinical findings of these patients. I wanted to know about pulsus paradoxus in the patients with COPD or asthma exacerbation, and maybe what its role might be, in the whole pathophysiology and maybe the other clinical findings. Doc, any ideas? Okay, so basically the other you'd expect that with that there will be a bit of delayed on auscultation. You might also expect a bit of delayed closure of the pulmonary versus the aortic valve due to the pulmonary hypertension. So there may be also be, if you auscultated S2 specifically, you'll probably find a split. And depending on the kind of obstruction you're having in airways, you might have a dynamic or fixed split, but nonetheless, it will usually be a split of the two sounds that make up S2. Pulsus paradoxus really refers to the variability in the blood pressure with breathing. And in this case, due to air trapping and increased intrathoracic pressures, there will be variation with inspiration and expiration in the venous return to the heart. So you expect pulsus paradoxus, and when it's present, it tells you there's quite a good amount of air trapping going on, and maybe this patient needs to be receiving a bit of care. It's actually quite a useful clinical sign in patients who seem to have gotten better after you have treated them for asthma and COPD. They don't seem to have an active distress. But when you check that they're actually having evidence of pulsus paradoxus, then you might want to keep them a bit longer, because it means within those lungs there are still areas which are obstructed and not yet not yet exhaling fully to deflate. And you can assess for pulsus paradoxus. Well, the ideal is if you had like an arterial lining, you can see actually the variability in the blood pressure. The poor man's way of doing it is just looking at also the variability in the waveform. The arterial waveform, there will be an exaggerated drop in the in the waveforms between inspiration and expiration on the plethysmograph, and the other one will be taking measurement of the blood pressure. It's quite difficult for a patient who is sick for you to ask them to hold their breath to take measurement in inspiration and expiration. But I mean, ideally, that is what the description in your clinical methods books says. So back to Dr. Cornelius for moderation. That is the question I have. Thank you.
All right, thank you very much, Dr. Rasmus. I'm going to start the poll now regarding pathophysiology of obstructive lung disease, and then at the end of which we shall request Dr. Kamara to give her responses based on what the audience answers. So here it is. You should be able to see it now. We shall give it perhaps 3 minutes to complete this. At the top of the hour, we should be able to share what the results are. In case you don't see the poll, please go to your, in case you're using a laptop, you should be able to see polls and quizzes. And in case you're using a phone, there's a 3-dot menu that you can tap, and then it should be able to open up your poll and quizzes. Okay, 1 minute is done, so 2 more minutes, and we shall close the poll. Do not worry about being right or wrong. We are all here to learn. Okay, the answers are now coming in. So we have about 1.5 minutes left. We shall probably close the poll if more than a quarter of the audience has responded. At the moment, we are about almost 18% have responded. So at 25%, I'll probably close the poll. Or if 3 minutes elapse. All right. Okay, we'll give it the last minute, and because we are now submitting the responses. Okay, we're going to close the poll in the next 10 seconds. All right, I'll end the poll now. Sorry for those who are still submitting. So I will share the results. You should be able to see the results. So the first question, Dr. Kamara, is which of the following is a hallmark feature of obstructive lung diseases? The audience, 71% selected decreased forced expiratory volume in 1 second. That's FEV1 to forced vital capacity ratio. That's the FVC. The other options were reduced total lung capacity, increased FEV1 to FVC ratio, decreased residual volume. Dr. Kamara, what's your take on this one?
So the audience is correct, I believe, because in obstructive lung disease, we know that we have this is a disease where expiration is impaired. So normally there's a volume of air that you can expel in one forced expiration. That's the forced vital capacity. And then there is the volume that you can expire in the first 1 second. That's the forced expiratory volume. And about 80% of that air should be expelled in the first 1 second. But in obstructive lung disease, you have a decrease in the volume of that, in that volume of air that you can expire in the first 1 second. So, and that is the hallmark sign of obstructive lung disease.
Right.
Yes, I think
Thank you very much.
correct.
Yeah. So question 2, in chronic obstructive pulmonary disease, airflow limitation is primarily caused by, so here options are bronchial hyperresponsiveness, loss of alveolar elastic recoil, and small airway collapse, immune-mediated destruction of the alveolar walls, vascular remodeling, and pulmonary hypertension. The audience, 57%, chose loss of alveolar elastic recoil and small airway collapse. What's your take?
Again, I think the audience is correct, the majority, with loss of alveolar elastic recoil and small airway collapse, because the airflow limitation we have is mainly in expiration and not in inspiration. So the loss of alveolar elastic recoil and small airway collapse negatively affects expiration. It prevents air. It prevents air being expelled because you do not have that the pressure gradient that would have been reversed during a normal expiration can no longer operate that way. You have no elastic recoil. The alveolar pressure cannot exceed the atmospheric pressure easily, and that causes that is the main airflow limitation we have. Although the bronchial hyperresponsiveness is present and we have destruction of the walls, the main airflow limitation we have is the expulsion of air from the alveoli out.
All right, thank you. Question number 3 is, which of the following is the key pathophysiological difference between asthma and COPD? The first option is asthma is characterized by reversible airway obstruction, whereas COPD is not. Second option is COPD is mediated by eosinophils, whereas asthma involves neutrophils. Then the third option is COPD is primarily restrictive lung disease, asthma is obstructive, and last option is airway remodeling occurs only in COPD. The audience, majority 83%, selected asthma is characterized by reversible airway obstruction, whereas COPD is not. Your take?
Yes, the audience is correct. Again, this is the main feature that distinguishes asthma from COPD. So like I mentioned, clinically, the patients present the same clinically. They all have dyspnea chronic, they have exacerbations. So they use a spirometry to distinguish between the two. So in spirometry, they check the forced expiratory volume ratio to the forced vital capacity, that ratio of FEV over FVC. So in asthma, you will have a reduced ratio. You'll have reduced ratios in both asthma and COPD. But after giving a bronchodilator, the patients with asthma will now register a normal ratio, and the ones with COPD will still have a low ratio, and that's how they distinguish. So yes, the audience is correct.
All right, thank you. There's some interesting analogies to that. Is asthma is like a door locking, and then you just get the key and you open it. So the key is like the medication to just open up. While COPD is more like a rusty door that is stuck, and then the medication is like lubricant to try and open it, but the door never fully opens. So that's sort of the way that differentiates the two. And then so COPD patients. The fourth question: COPD patients, when given too much oxygen, may worsen due to loss of the hypoxic drive. True or false? 77% of the audience said true. Your take?
I would agree with the audience, although if I may allow me to say, recently you shared some new state studies that were debating this hypoxic drive and its existence. However, I would think the audience is correct, as that's what we've always been told, that the loss of the hypoxic drive causes this. But looking at the pathophysiology, I'm not so sure.
It's a myth that we have been told for a very long time, and I think in the first session of Pulmonary Madness, we had a similar question to this. The hypoxic drive is a myth, and one of the functions of these seminars is to destroy myths. So the hypoxic drive does not really exist in COPD patients. Even though they get worse, the actual mechanism that leads to them getting worse has more to do with blunting some of the reflexes that happen within the lung that you talked about, like the hypoxic pulmonary vasoconstriction, but also there are other physiological concepts that enhance increase of carbon dioxide within these patients when you give them too much oxygen. So I think the article I shared summarized a majority of studies that have actually looked into the pathophysiological mechanisms. So I will encourage everyone to just go back and look at those articles. Let's not go by what we were told, let's go by the evidence that is on hand. So on this one, unfortunately, democracy does not carry the day. The audience, the majority is wrong. Question number 5, in acute asthma exacerbation, which of the signs would prompt an urgent critical care review? First option is bilateral wheeze. Second option is inability to complete sentences. Third option is partial pressure of carbon dioxide of 44. And last option is partial pressure of oxygen of 68 on room air. Audience 66% chose option 2, inability to complete sentences. Dr. Kamara, your take.
The audience is correct. Inability to complete sentences is an indication of impending respiratory failure. So that's what would prompt an urgent critical care review.
Excellent. All right. Thank you very much. And we shall now hand this over to, if you can stop sharing your slides so that we can go to the next presenter. Dr. Thomas Atunyo is a graduate from anesthesia and critical care at Makerere University. He's a fresh graduate about 2 weeks ago or 1 week ago. So Dr. Thomas Atunyo, please share your slides and take away the presentation. Thank you.
How do we stop sharing?
Please just go to the stop share. It's usually up on your screen if you're using a laptop. Thomas Atunyo, I can see you. Your screen is on. Is that so?
Yes.
Please go ahead and start the presentation.
Okay, good evening, everyone. Presenting the management of the patient with obstructive airway disease. So the approach or the strategy to this is that we need to open the obstructed airways. We can start by looking at basically the pharmacological aspects to bronchodilate the airway. And we're going to look at the aspects relating to elimination of the inflammation, as we have seen in the pathophysiology. And then it's important to remove the secretions that are obstructing the airway. And then we'll also look at overcoming some of the complications that come along with COPD and asthma. That's the air trapping, how to manage it. And then, of course, looking at hemothorax and pneumothorax, and then patient ventilator asynchrony. And then it's also important to not to ignore the other comorbidities which may coexist or worsen the obstructive airway disease. So this is a brief initial evaluation of the patient who has obstructive airway disease. So we focus on looking out for the symptoms that help us to be able to differentiate this is a severe exacerbation. On this other right-hand side, we see recommendations from the Global Initiative for asthma, that is 2024. If we do the respiratory rate, heart rate, SpO2 of the patients, if we find them within these ranges, we may have to think this is an exacerbation. And then the Global Initiative for obstructive lung disease also classified the one for asthma, for COPD as indicated here. Addition to that, it's important to have ABGs done to enable us to know how we are progressing with the management of the patient with asthma and the COPD. It will enable us to know the improvement in the symptoms. The other thing is we have to look out for the microorganisms that may be causing the infection. Viruses, may need to do a blood culture. And then, of course, the other imaging modalities, the chest X-ray will help you look out for other comorbidities, for example, pneumonia. The ECG, you may find features of right ventricular hypertrophy due to increased pulmonary pressures. And the pro-BNP, looking out for comorbidities such as heart failure. And then also PE may also present or is a common finding also in those patients due to the nature of difficulty in breathing. They may be mobile, so to be a good idea to look out for the features suggestive of the same if you suspect a PE. And then point of care ultrasound will go along the way to also help us delineate some of the complications as we shall see along. So first of all, we begin with the bronchodilators. This quote in 2017 Cochrane review found out that if we combined a short-acting beta agonist, for example, salbutamol, and then a SAMA, short-acting muscarinic agonist, the ipratropium bromide, it would give a better outcome for the patient by reducing the duration of hospital stay and also reduce the ratio of the forced expiratory volume to the peak expiratory flow. So the other aspect is the corticosteroids. We have seen in the pathophysiology that one of the aspects that was important was the airway inflammation. Mainly for asthma would be seeing the type 1, the CD4 cells leading to production mostly eosinophils, and in COPD mostly T8 lymphocytes predominant with the neutrophils. So basically the steroids here do not have superiority one over the other. However, probably dexamethasone might have a bit of a longer half-life, but otherwise there's no superiority over hydrocortisone, dexa versus the methylprednisolone. So the other is magnesium sulfate for the patient who is now not responding to the SAMA and the SABA. It may come in handy in actually enhancing the effect, the bronchodilator effects of the short-acting beta agonists. In a dose of about 2 grams is where you start IV. And then second here, looking at still a controversial one is use of ketamine. Perhaps this you can consider when you are probably sedating the patient due to its bronchodilatory effect. However, there is limited data to support its use, routine use for both asthma and COPD patients. And then the other one is Heliox. That also remains to require more research to be done. Otherwise, it has been found that it helps to cause bronchodilation due to its lower density. And so therefore it decreases the airway resistance as one of the pathophysiologies we saw, which promotes a laminar flow and hence decreasing the work of breathing for the patient. So this was found to improve the patient's symptoms. However, there was no significant difference statistically. A significant difference was not found in terms of helping to lower the failure need for NIV in COPD patients. So still, Heliox is something that also still requires more studies to bring its use in the routine. Next is the adjuncts. We'll look at issues to do with antibiotics. This is only when you have a sign or proof of a possibility of an ongoing infection in the patient. So this is going to follow your local antibiotic biogram. In the beginning, we had discussed about the cultures. So once you've done your cultures, you will eventually align your antibiotics to the microorganisms that have grown. The other medications that have been used before that are discouraged in both asthma and COPD are the methylxanthines. And so much as they bring in the bronchodilation, they be discouraged for use because first of all, there's not a therapeutic window and therefore high risk of its side effects. And the outcomes of bronchodilation in COPD patients and asthma does not actually get any better than a SABA that provided to your patient. The same as tabutaline. Also, the evidence did not indicate that it was any better than a SABA. So you'd rather consider using the short-acting beta agonist. Now we move to oxygenation and ventilation modalities. So this is where our discussion is going to concentrate on. We have different oxygenation and ventilation modalities. The first one is supplementation of oxygen by either use of a face mask, a non-rebreather, nasal prong, you try to achieve the oxygen saturation in asthma of at least more than 92%, but probably less than 98%. And then in COPD patients, we indicated when the SpO2 is less than 88%, as we shall see in detail as we review that particular modality of administration. The next is the high flow nasal cannula. That is also indicated if there's persistent hypoxemia despite the use of these other oxygen delivery devices, which can also be deployed with the high flow rates. And then we have the NIV that also comes in if there is no improvement using the oxygen delivery modality such as the non-rebreather mask and nasal prong. You could as well deploy the NIV, but we'll see the comparisons between high flow nasal cannula and the NIV. And then of course, for patients who fail or go into cardiac arrest, there is an option of invasive mechanical ventilation. We shall see the details of this as well as the subsequent slides. And the last one there would be the veno-venous ECMO, which is an advanced method. So supplemental oxygen, what is key is that you notice that even in severe life-threatening asthma exacerbations, rarely do patients actually have hypoxemia to the extent of having a partial pressure of oxygen less than 55, or rarely do they require an FiO2 more than 30 to 50%. So if you find your patient requiring so much of FiO2, that should prompt you to look out for a possibility of other causes. However, oxygen ideally is titrated to values of about 93 to 94% in a patient with asthma and about 88 to 92% in COPD. We have to notice that excessive oxygen administration or hyperoxia can actually promote hypercapnia due to worsening of the VQ mismatch, especially due to inhibition of the pulmonary vasoconstriction. And there is also an aspect of the Haldane effect. We will remember that when the hemoglobin is highly saturated with oxygen, there is a tendency to release CO2. And therefore, there will be more CO2 circulating in the blood, and this also sort of worsens the hypercapnia. Next is the high flow nasal therapy. So what's important to note here is that the high flows up to 6 liters per minute given by this enables it to eliminate CO2 from the upper airways. And this is also able to generate some positive pressure that recruits the atelectatic lungs or alveoli, thereby helping to improve the VQ mismatch and also helping to improve on compliance. It's important then to note that the high flow nasal cannulas are not necessarily proven to be very effective in patients with both asthma and COPD. However, they are more applicable in a situation where you would consider an NIV as in like alternating the high flow nasal cannula and NIV mask. If the patient is unable to tolerate the NIV, then you could as well first change to the high flow nasal cannula. In alternation like that, it's been found to provide better results than when used alone, but it's not anywhere superior to the NIV. Next is the NIV. So the external PEEP applied by the NIV helps again to recruit the alveoli. And also in this case, it helps us to reduce the negative inspiratory force that's required to overcome the extrinsic, the auto PEEP, okay? And also by so doing, the positive pressure that has been created by the hyperdynamic inflation, hyperinflation due to the airway obstruction as a result of reduction in the recoil of the lungs and so of the airways. So basically what that helps us to do is that the external PEEP that is applied would help us to overcome that positive pressure in the alveoli. And at the same time, we will need less negative inspiratory force in order to overcome the auto PEEP, and thereby enabling the patient to trigger the ventilator as an assisted breath. So again, also NIV helps to improve generally the patient's CO2 level, reducing the CO2 levels, and also helps to improve hypoxia and helps the patient improve on workout breathing. Important to note is that a global initiative for asthma guidelines do not particularly recommend the use of NIV in patients with asthma. However, this NIV has been preferred as an initial modality for patients who have COPD. So we go next to what sort of settings that you want to put on your vent for ventilating a patient with using NIV. So what the principle here, or the most important aspect, is to titrate the PEEP and then your pressure support in such a way that you do not end up causing worsening of the hyperinflation, which already exists in the alveoli. And then also when you titrate your pressure support, we want to start with low tidal volumes of about 6 to 8 liters, mils per kg, per kilogram of ideal body weight. By so doing, you will achieve a lower tidal volume and at the same time, not hyperinflating the alveoli. So it's important to observe that principle. However, if the patient remains persistently hypercapnic, you can titrate the pressure support up to increase the minute ventilation, which is a function of the respiratory rate and the tidal volume. So patients with NIV will usually require some form of sedation and analgesia to be able to tolerate the NIV. And in this case, dexamethasone has been found to be more useful because of its lack of respiratory depression. It's important to always do regular blood gas analysis for patients who are undergoing NIV treatment in order to detect early failure rates, and also perform your physical exam to be able to know a patient who is in distress. How do we know that there is failure for use of NIV? And so these are some of the things that you can look up for. If the patient is persistently hypoxic or persistently hypercapnic despite 1 hour of NIV use, that should prompt you to know that this patient is likely failing on NIV. However, due to the new developments as such focus, you could as well do an ultrasound scan and then look out for the changes in the diaphragm thickness. As you may notice in that diagram, there's that smaller portion of the diaphragm indicated here as the thickness at end exhalation. And then we have the thickness of the diaphragm at end inhalation. So when we get that difference, the percentage is what we're seeing there as the 20%. If it's less than that 20%, you're probably going to portend towards a possible NIV failure. Second to that, we can also do this heart rate, acidosis, consciousness, oxygen, respiratory rate score. So a score of more than 5, if you look at all those values, might suggest that the patient could be failing on NIV. So the last aspect here is the invasive mechanical ventilation. So this is now for a patient who has failed on NIV. So invasive mechanical ventilation may also, just like NIV, worsen the hyperinflation due to its due to the ability to do what? To decrease the venous return, and therefore that the when you have a decreased venous return to the right side of the heart, this patient is going to get hypotensive. So you have to keep that at the back of your mind. So it's important that you optimize the patient prior to intubation by resuscitating with vasopressors and intravenous fluids. You'll have to know that this would be a physiologically difficult air. So you'll prepare possibly to do a rapid sequence induction. If the patient already was on NIV, might have been blowing a lot of air into the GI and already distending the GI with the risk of aspiration. So ketamine or ketofol in this case, that ketamine has a bit of, due to the bronchodilator effect, would be a preferred agent here for your induction. It is also important to note that we need to use larger ETT sizes appropriate for the size. If it's an adult male, we would prefer to use an 8mm ETT tube, because this helps you to reduce the airway resistance, and also it will help you to, when you're suctioning the patient, and also helps with the reduction of the peak pressures within the airway. And in case you also needed to do a bronchoscopy to look into the lungs, you can still be able to use the same large ETT. So ETT is very helpful. A light one is very useful in this pathophysiology of asthma and COPD. So what are the ventilator settings? In the initial settings for the patient with COPD and asthma. So preferably, we would put the patient on a volume controlled mode of ventilation, just because probably there's no any much significant difference with the pressure controlled, only that the pressure controlled mode will vary the volume that is delivered to the patient, and we already have challenges with hyperinflation of the alveoli. So we prefer something that controls a bit of the volume delivered, but no specific superiority of a pressure support mode, pressure controlled mode. The FiO2, like we said again before, that we want to target just to achieve SpO2 about 88 to 92% COPD, but at least less than 98%, because of the effects of triggering of hypercapnia that we already explained, that comes as a result of increased pulmonary hypertension or pressures, and then as a result of the Haldane effect, once you have administered a high concentration of FiO2 of oxygen. Then you also want to start usually with a lower respiratory rate, because lower respiratory rate, as well as the other factors that we have looked at, including, as we shall see down, the time in inspiration, will also help to allow you enough time for the patient to be able to expire. So it's important to start low, although we will allow what we call permissive hypercapnia. So you start low and then progressively increase, but you can look at the pH of about 7.25 to about 7.35. It's allowable for your patient not to be able to distend the alveoli. Again, the other aspect is if you just found your patient that is on a vent already having a normal pH within a few hours of being on mechanical ventilation, just might be a sign that actually that pH might signal that the patient is getting into respiratory failure rather than improve, just because that would expect that you will not be able to achieve that in that short while due to the CO2 levels we discussed above. Now, the tidal volume, we also want to start with a low tidal volume. Again, we're trying to maintain a low minute volume. So in this case, we're trying to prevent distending the alveoli and therefore stopping to worsen the already existing auto PEEP. And so we start with the 6 mils per kilogram body weight of an ideal body weight, and then we shall titrate according to achieve a pH of about within that range. The next is the inspiratory flow, as we shall see later in management of auto PEEP. So the flows of about 60 to 100 will also in a way help you to increase, actually decrease the inspiratory time and increase the time for expiration, because the problem is expiration. So we need to give the patient enough time to expire the CO2. And then PEEP, also you want to start with a low PEEP. Usually anywhere 0 to 5 will enable you to avoid aggravating the already available auto PEEP. And so we will see where we'll need to increase PEEP later on in the course. The trigger, if you're using a flow trigger, you could start also with a low trigger of about 2, but again, you don't want to come below less than 2 liters for flow triggering, because otherwise the ventilator will start auto triggering and then cause ventilator patient asynchrony. If you're using pressure sort of cycle triggering, then there you might want to use anywhere -1 and -2 centimeters of water as the initial trigger. Now that we have discussed the initial ventilator settings, we want to look at the complications that may arise and how we monitor for them. It's important to look out for auto PEEP, as we can see in this chart here. When your curve doesn't go back to 0 line, that could be a sign that your patient is retaining air in the lungs, is not exhaling up to 0. And so the other thing that we do then is to measure the plateau pressures. We may not be much worried of the peak pressures here because already there's increased pressures already in the upper airway. The plateau pressure basically measures the static compliance, which is a surrogate of hyperinflation. You found this already elevated high, it will point towards hyperinflation. So we want to keep the plateau pressures at least below 30 centimeters of water to avoid barotrauma that can result from the high pressures you're using for ventilating. And then for the ventilator, if it keeps triggering the alarm for peak pressure, this you could increase the setting so that we will not keep triggering the vent, because already expect that there will be a lot of resistance on those airways. And so if a patient has significantly elevated plateau pressures, you may need to look out for other associated issues like pulmonary edema, pneumonia, pneumothorax, and a pleural effusion. So these are two things are important to monitor: the plateau pressure and the ability of the curve to return back to 0 for auto PEEP. So how do we treat once you find that the patient has an auto PEEP? What shall we do? So the idea here is to increase the time that's needed to allow the patient to expire. And how do we do this? We can decrease the respiratory rate and then also decrease the inspiratory time. And therefore, when we do that, we shall be allowing more time for the patient to expire. And then we will also increase the inspiratory flow, like we saw above, at least 60 to 100 liters per minute. All those will help us to do what? To manage this challenge of auto PEEP. Next is the tidal volume. We'll want to decrease the tidal volume as well, so that we do not end up distending already hyperinflated alveoli. However, these two things, decreasing the tidal volume and the respiratory rate, can again actually lead us into accumulating CO2 because the patient is not expelling it adequately. In such situations that the patient now is accumulating again more excessive CO2, we can temporarily disconnect the ventilator, the breathing circuit, so that you allow the decline of the auto PEEP and also help to improve the venous return back to the right side of the heart, so that the patient will become hemodynamically stable. Next is, second last slide probably, is a patient ventilator asynchrony as one of the complications we looked up. So what is this? This is basically a mismatch between the ventilator breath and then the patient's initiated breath. The challenge with this is that it will lead the patient to have increased stay on the vent and also increases for mortality. Therefore, this has to be dealt with. How do we know this? We find that the patient will be struggling on the vent. And then we'll also look at the ventilator, the flow volume curves that can enable you to detect that there's a patient ventilator asynchrony. So in this case, we must look out for and treat the bronchospasms, again with nebulization with the SABAs and the SAMA, and also deal with the airflow obstruction, suction the airway appropriately. And then if the patient is spontaneously breathing, we may also want to reduce close the gap between the trigger, which has been set, and the auto PEEP. So we can do that by at least increasing the PEEP by 70 to 80% of the auto PEEP, so that we can be able to deal with the ventilator asynchrony. If the asynchrony is persistent, a patient may benefit from a short-term neuromuscular paralysis. You paralyze the patient so that you allow the ventilator to be able to deliver the breath without interference with the patient's initiated breath. Lastly, we look at the advanced therapies, but this, my colleague who is coming next, Senior, will discuss the ECMO. But again, here, venovenous ECMO is indicated for patients with severe hypoxia, hypoxemia, and hypercapnic. Despite you optimizing the mechanical ventilation, the patient still remains hypercapnic and still remains hypoxic with hemodynamic instability related to the hyperinflation of the chest. So, however, if your patient is already in multi-organ failure or requires a very high level of FiO2, or has a bleeding diastasis or any contraindication to anticoagulation, then ECMO then becomes contraindicated. It will not be beneficial. So important to note is that we also titrate this to achieve the SpO2 goals. However, we try not to rapidly reduce the CO2 elimination beyond 22 millimeters of mercury or by 50% within the first 1 hour, or whichever comes first, as this been found to be associated with neurological complications such as ICH, ischemic strokes, and brain death. Lastly is how do we extubate these patients who are COPD and asthma? Basically, it's been found that NIV, when a patient is extubated and put on NIV in the same ventilator settings they were on when they were in invasive mechanical ventilation, they seem to do better. Okay, or you could use NIV or high flow nasal cannula in alternation for extubating a COPD patient. However, the same have not been found to be useful in patients with asthma. So what are we taking home? The key tests, POCUS is important in helping us to know NIV failure. We can be able to find out other complications relating to COPD and asthma. A chest X-ray goes without mention, and ABG for monitoring treatment. And then secondly, that NIV is basically recommended in COPD exacerbations, initial treatment, but really not much role has been found for asthma exacerbations. And then again, in patients on invasive mechanical ventilation, it is very key to monitor the plateau pressures and the auto PEEP. Plateau pressures must be kept below 30 centimeters of water. Fourth one is that NIV and high flow nasal cannulas can be used in alternation if a patient cannot tolerate NIV alone. Fifth one is that normal CO2 levels in severely tachypneic patients should not make you excited and go and take a cup of coffee, but rather worry that the potential ability of your patient is a tendency that your patient may be going into what? Respiratory failure. Second last is that high peak pressures during minute ventilation is not what your big worry is. We already know that there is increased resistance in the airways. Rather look out for the plateau pressures and keep them below 30 for your ventilator settings. The last one is that we do not want patients who are on ECMO to immediately reduce the CO2 levels by more than 20 or by more than a half within the first 1 day, as that is associated with neurological complications. I thank you very much for your audience. Welcome questions now. Back to you, Dr. Cornell.
All right, thank you very much, Dr. Antonio. So there are some questions in the chat. I will ask, and then you can respond to them. So how much air pressure transmits to the pulmonary arterial circulation, and thus RV and CVP? These two questions are coming from Dr. Erasmus to you.
Pardon again on the question. I'm trying to scroll to see what.
So how much airway pressure transmits to the pulmonary arterial circulation, and that's the right ventricle and the central venous pressure?
Well, I do not have a particular figures of how much pressure eventually transmits to the pulmonary artery, but what we know is that there is an increase in the pulmonary arterial pressures and the pulmonary circulation that has an impact in itself, worsening the VQ mismatch that could lead to a patient still being hypercapnic despite us actually initiating the oxygen delivery mechanisms. That's how I respond to that. I will allow Dr. Rasmus to add more. Then second question is how would you approach?
So before you go ahead,
Yeah.
Rasmus, would you like to come in for question?
Yeah. So generally, if you are talking figures, is right. Basically, we don't know the exact figure, but the arbitrary figures accepted from physiological studies are that, if the patient's lungs are of normal physiology, they have no pathology in them, you're probably transmitting about 50% of the mean airway pressures to the circulatory system. And that means your CVP might go up by about 50% of what the mean airway pressure is if you're on ventilation. And if the lungs are quite consolidated, then you're looking at maybe a maximum of about 25% of the airway pressure being transmitted to the circulation. And when the lungs are hyper, elastic, like in the case of COPD, they are very compliant. Then a lot of the airway pressure will be transmitted, in the region of about 75%. So this is key to think about when you're setting your ventilator and thinking about the effect of your vent on the patient. You might have a very small airway pressure, but the patient actually is getting compromised hemodynamically because the airway pressure is getting transmitted to the right ventricular, to right circulation, and thereby impairing venous return.
All right, thank you very much. Dr. Atunya, the next question is, how would you approach intubation of a near fatal asthma or COPD exacerbated case?
Okay, so again, near fatal asthma, we have to recognize that this is, first of all, a physiologically difficult airway, in the sense that the patient is hypoxemic, and at the same time, there is hemodynamic compromise. So in this kind of situation, if you must intubate the patient, we would consider using a rapid sequence sort of induction, because we already believe that, that the NIV mask you have used probably before has already distended the abdomen. There's risk of aspiration. And then we need to consider drugs for induction, such as, ketamine, that also maintains your airway patent, or also consider, stabilizing your hemodynamics, ensure that you are probably a patient, if not already in pulmonary edema, at least is the fluid, you've given an IV fluid, say bolus, that was necessary to sustain the hemodynamics. And also maybe you have already your noradrenaline running to maintain the blood pressure. And then once you do your rapid sequence induction, certainly we'll start with the mechanisms that are kind of lung protective that we already discussed earlier. And possibly also in this case, if you not already used bronchodilator, maybe it's such a time that you also nebulize them prior to, just to also numb a bit of the airway reflexes, just so that we can improve on the success rate without triggering any bronchospasms. That's how I would approach it. I welcome contributions.
Okay, thank you very much, Dr. Thomas. Dr. Rasmus, anything to add to that?
Again, these are quite tricky patients and definitely physiologically difficult airways. And unfortunately, this is a stage where, whereas we want to avoid intubating asthma or COPD patients as much as we can, this is a stage where the reality is that they're going to die without you attempting to intubate them. And they could die during the process of intubation. And, in centers where it exists, these are patients where the team might elect to just get in the ECMO team to just place in that echo core or ECMO, to support the patient so that they don't have to intubate entirely. But when you must intubate this patient, then the precautions Dr. Tunya has talked about are key. You definitely want to get the drugs in that do not knock out the patient's respiratory drive, so they continue to breathe. So things like ketamine, things like things like ketamine to keep the airways, the patient airway reflexes on, but also keep patient breathing might be helpful. You might also, if you can, kind of numb the airway, sure. But the key is get these drugs that are going to work very fast and have the best person at intubation be at the head of the patient. And if possible, preferably maintain the FRC by keeping the patient seated up a bit more upright, maybe 45, 60 degrees, so that the patient's FRC is sustained, allow the patient to breathe, and then, zap them to sleep. Sometimes you can go ahead with the paralytic as well and put in the tube quite quickly. And the most delicate time is once the tube is in, which almost all of us will be able to throw in blindly. It is how you're going to handle the ventilation of these patients. And frequently, because of the anxiety around it, someone's going to bag the patient quite hard. And that's usually the last bag of air the patient is going to receive. And many times the person will be saying, okay, we intubated, but the patient died anyways. And maybe, it was God's will. But usually it has been your will indirectly because of how much air you pumped into that chest, which basically filled the right ventricle. So I think overall, just a small addition there to what Dr. Tunya talked about. But yes, if you can avoid, if you have the resources to avoid, and you can maybe go to extracorporeal means for these patients, perfect choice in that situation.
All right, thank you very much. So we have one more question in the chat room for you, Dr. Thomas. And after that, we shall not take any more questions. I will request that you post them and Dr. Thomas will respond to them in the chat. So Dr. Thomas, from Adamo, considering air trapment that happens in a patient with COPD, how do we optimize ventilatory strategies while minimizing washing away of CO2 present in them and avoiding hyperinflation and worsening the auto-PEEP?
Not quite sure that I picked the question, but if I may hear it very well, that how do we get off excess CO2 without necessarily worsening the auto-PEEP?
And hyperinflation. And
hyperinflation, yes. So if you went back to the slide on management of auto-PEEP, we'll realize that the aim in ventilating this patient is not necessarily to correct the CO2 back to within 35 to 45, but you have to allow what we call a permissive hypercapnia. In so doing, you're going to titrate your respiratory rate in the lower ranges that help the patient to improve the symptoms, say, of dyspnea and the increased work of breathing. So that you have to titrate a respiratory rate and your inspiratory time, probably lower inspiratory expiratory ratios of around 1 to 2 to 1 to 4. At the same time, increasing your flow of the vent to at least to 60 to about 100. In so doing, you will be able to increase the expiratory time and therefore allow much CO2 to be exhaled. But this is going to be a question of balancing, not trying to achieve in the shortest time possible complete normalization of the CO2 levels, against improving the patient's symptoms. So maybe that's how I would answer his question, if I understood it well.
All right.
But also maybe there was an aspect of disconnection of the ventilator. I don't know if he remembers that. For allow us briefly to also do what deal away with the auto PIP.
All right. Okay. So we are really badly running out of time. I'm not going to launch the question because of that. So I'm going to request Dr. Claire Bakker. So Dr. Claire Bakker is an intensivist and an anesthesiologist who returned to Uganda after her 1 and something years of training in Cambridge, where she had a lot of experience in extracorporeal respiratory support. So I will invite her to share the advanced side that Dr. Atunyo hinted on in his slide with regards to management of patients with COPD exacerbation beyond the capacity of ventilatory support. Dr. Claire, I will ask you to share your slides and proceed to present. I'm not sure if Dr. Claire is on. I think she got, oh, she's on. Dr. Bakker, are you there? In case you're talking, your microphone is muted.
Hello.
Yes, go ahead, Dr. Claire. There's feedback on your side.
Sorry, Cornel, kindly requesting to for some using my laptop for the presentations, if you can actually make me on the laptop and the phone. I'll go.
Dr. Claire, are you still with us? I think we've lost her. Dr. Rasmus,
Yes, sir.
do we, so I didn't pick up what Claire said. We were having quite an amount of feedback.
Yeah, so I think she had 2 devices and she was trying to to one so that she could use one. I guess a bit of a technology issue. But maybe as we wait, I just wanted to chime in on a bit in the literature regarding obstructive airway diseases and critical ones is that it has some aspect of people compressing the chest of the patient. It's kind of old school stuff, and some older people really swear by it and they continue doing it. But there have been quite many fatal events resulting from compressing the chest of a patient who has got air trapping and near fetal state. And it should definitely be discouraged. Really, these guys suffer, first of all, from acute rise in pulmonary resistance and right ventricular failure, so they suffer cardiac arrest. But if they survive that, some of them end up with the dissection into the airways, the rupture of the air sacs, and embolism, pneumothoraces, and the like. So it's really quite a dangerous thing to do, much as some people are ballsy enough to do it and kind of do it and have no adverse events. So really just a word of caution here. So over to Dr. Claire.
All right, Dr. Claire, take it away.
Hello, I hope you can hear me.
You can see your slides. Do you mind using the slideshow?
Right.
Yeah.
And perhaps get closer to the microphone, a bit far, distant.
Right. So my name is Claire. I've just been introduced. I didn't have much in terms of experience with ECMO, but I'm here to share the little that I did. So basically, we're going to look at what was put out there was extracorporeal respiratory support. Am I very clear? Am I loud enough?
Yeah, you're loud and clear. You're loud and clear. Please go ahead.
Okay. Yeah, so, but I will also talk about extensively to basically extracorporeal life support, which also has a bit of cardiovascular part of it. So, sorry. Oh, yeah. So that's a basic ECMO circuit right there. And like we spoke, the indications for ECMO have already been emphasized, and so majorly it's for patients with reversible refractory respiratory failure and cardiovascular support. So when we look at this circuit, yeah, we so basic ECMO circuit is composed of a pump, and that's a centrifugal pump, which basically pumps blood from the drain cannula. So in this case, we have a cannula which is inserted via the femoral and is draining from the inferior vena cava. And this pump takes this blood through the oxygenator, which is composed of hollow fibers, and that's where gas exchange happens. We have the sweep gas flow, which is delivered into the oxygenator, and that's what delivers oxygen, and blood picks up this oxygen, and then also this carbon dioxide removal from the same part, and then this blood is taken back to the patient, to the body, and through the return cannula. And so that's just basically what it looks like. To emphasize, there are factors that determine oxygenation of this blood, and also those that determine CO2 removal from the oxygenator. And one is the extracorporeal blood flow. So when you have low flows, that could affect the oxygenation of the blood. So there has to be adequate flow for this blood to pick up oxygen. Also the HB concentration, basing on the oxygen content equation that has been talked about a lot during these presentations, your HB concentration matters a lot. And in so many studies, any HB less than 7 has shown to increase mortality. And however, between 7 and 10 is what is recommended. But the different, there's 7 and 10, and but anything less increases mortality. Or the other factor is the pre-oxygenator oxygen saturation, and here we'll talk about the concept of recirculation. So if you have blood that has been taken back into the patient, and some reason joins, it returns back through the circuit before going to the patient. Most times this blood is going to be already saturated, the HP is going to be already saturated, and it can only be 100% saturated. So if you have resaturation, that's going to actually affect the oxygenation. The other thing is about diffusion through the hollow fibers. So if you have any clots or thrombus in the hollow fiber, stuck in the hollow fibers, maybe in inadequate anticoagulation states, that could affect the oxygenation. CO2 removal, on the other hand, is based on the CO2 dissociation curve is a bit more steep and linear. So you have, and the fact that you have a high solubility of carbon dioxide, so it easily diffuses out. The only factors that are going to affect carbon dioxide diffusing out are, one, if you have a clot again within that, the microfibers, if you have the surface area of the oxygenator is less, and also those will affect. And the fact that the sweep gas flow is most times pure, is 100% of oxygen or a mix, and it contains less carbon dioxide, so there's already a diffusion gradient, so there's easy diffusibility of carbon dioxide out of the patient's blood. It's important to note, these are the indications of ECMO, as it's really been talked about a lot. We have to have refractory, hypoxic, respiratory failure, which is well defined. In this case, this criteria varies, but we find that from the ECLS guidelines, that's I got this from the ECLS guidelines, but they're not absolute. They vary in different, like for example, the EPF pressures are going to vary in different institutions or sites and all. So the first one, refractory hypoxic respiratory failure, and this is also after trial of prone positioning, and it has to be reversible. Hypercapnic respiratory failure, which is also we're looking at in a reversible condition, and this is also refractory to all the lung protective mechanical ventilation and respirators of 35. The other indication is ventilatory support as a bridge to lung transplantation. So all those patients who are awaiting lung transplantation can have ECMO prior to as they wait if their lungs cannot sustain them. And also if a patient has had primary graft dysfunction and they are waiting another transplant. Cardiogenic shock as well, and refractory cardiac arrest, but patients in refractory cardiac arrest, they have to be selected carefully. And it's most times those patients that we think are going to have a meaningful recovery post cardiac arrest are the ones that have it. The absolute contraindications, and one of them is any critical comorbid conditions that preventing bridge to meaningful recovery. The rest are relative contraindications, which include age. So those, so there's so many studies that have demonstrated different age groups, but that's for us to go and look at. mechanical ventilation for more than 7 days, because after the 7 days, we think that there's already ventilator-induced lung injury, which could, so those patients, if you've been on mechanical ventilation more than 7 to 10 days, they are, it's a relative contraindication. And also there's contraindication to anticoagulation, especially in patients who already have like CNS hemorrhage or other system uncontrolled hemorrhage, because again, it requires anticoagulation for the patients to actually have the ECMO done. Immunosuppression is the other contraindication, inability to rehabilitate post-ECMO. Those are patients with irreversible, incapacitating CNS pathology or end-stage or significantly life-limiting comorbidities. Also, if you have any anatomical contraindications like vascular diseases that prohibit cannulation, that's another contraindication. So the different configurations of extracorporeal life support, and for different indications, we will go through most of these, but in particular, we start with hypercapnia. If you have hypercapnia without hypoxemia, so these patients can have mostly ECCO, this is carbon dioxide removal, and also low flow venous ECMO. This is basically only for CO2 removal, but if you have hypercapnia with hypoxemia, those patients, the modality of choice is venous ECMO, and this is without shock. So if you have cardiogenic shock, if you have any form of cardiogenic shock, then we will, if you have cardiogenic shock, then most of the modality will be veno-arterial ECMO, veno-arterial and other hybrids. Yeah, this particular device, PA to LA pumpless device is important mostly in isolated RV failure, because yeah, as we'll see. So venous ECMO, so we already, so this is the basic ECMO circuit where blood is drained or aspirated from, in this case, the IVC via the femoral vein, and it's pumped through the oxygenator, and this is where oxygenation happens and CO2 removal happens, and then the blood is returned back to the SPC through the right IJV. In this case, important to note that there are many modifications of this. We have, if for example, there's need for increased flows, we can have sorry, apologies. There are cases where the modifications in this case is you can have blood drainage from any, from the SVC or IVC, either via the IJV or the femoral, and also you can have from both SVC and IVC, and then that's the bicable one, and then you get blood draining back to the superior, the right atrium. So there are so many modifications of this, but we'll just stick this for purposes of keeping the presentation short. So before we move on, there are important factors that I need to mention. The last presenter talked about why in the first place. So the indication for veno-venous ECMO here, this modality is best suited for hypercapnic respiratory failure or hypoxic respiratory failure. But he also mentioned that in case a patient has hypercapnic respiratory failure, that the flow rates have to be less for the first few hours. That is going to be, the CO2 removal has got to be very slow because of the risk of cerebral vasoconstriction, which could cause cerebral hemorrhages. The other thing is, in case of hypoxic respiratory failure, the flow rates actually have to be higher, because that's one of the determinants of oxygenation. So there's going to be a balance between the blood flows have to be balanced to avoid the complications of both. Going on to the veno-arterial ECMO, we can see that the blood is draining from the venous system. So in this case, again, from the femoral vein. So remember, the blood has to drain from a central vein, but through a peripheral, through the peripheral cannula. So this blood is being drained from the IVC through the femoral vein, pumped through the oxygenator, and then back to the femoral artery. Now, the indication for veno-arterial ECMO is for those patients who require cardiovascular support. So in this case, we have blood returning from the femoral, from the circuit through the femoral artery, and it is being pumped up to the aorta. Now, this blood is pressurized, and once it gets into the aorta, it is pumped to the rest of the body. So if a patient has preserved, if they have some LV function, it means that there's going to be blood flow coming through the heart to the proximal aorta. And that blood is going to be mostly deoxygenated, since it's not the same, it's not the blood that's going through the circuit. So this deoxygenated blood, you find that will mix with the pressurized blood from the circuit, which is oxygenated. And at the point where they meet from the proximal aorta and the distal aorta, the point where they mix is what they call the mixing cloud. And it can be either, it could be higher up or it could be lower, depending on on the LV function. If there is minimal LV function, you find that this blood that is returning is actually pumped way back up to the LV itself, and you might find that we will have what we call the LV will fill up because it's not pumping, and then that will actually cause other complications and might end up with pulmonary congestion. So basically a backflow. But when you have some LV function, the mixing cloud is much lower, and in that case, you find that most of the deoxygenated blood is actually perfusing the brain and the right arm. So it's important that the monitoring of the oxygenation in the right arm, which is also going to reflect cerebral oxygenation, happens, because if then that can that can help to monitor for when the LV function has improved. So that is basically, and what I've just discussed is the peripheral veno-arterial ECMO. There is also central veno-arterial ECMO, which can only be done if sternotomy is done, and cardiotomy, and they put the central, they put the cannula, right, the cannulae within the heart itself. But this is done in an emergent situation when a patient needs cardiac support, and there's no time to actually go on for cardiotomy. And yeah, so there are different indications for this. There are complications of peripheral veno-arterial ECMO, and also which include, first of all, if you see here that we have pressurized blood that is coming through this cannula, so there's so many risks of this, one of them being limb ischemia, but also we can have thrombi formation, and so you can easily form a clot because this blood actually goes back up, and so you can also have a stroke from that. So what is actually more physiologic is the antegrade blood flow from central veno-arterial ECMO rather than this peripheral veno-arterial ECMO. Moving on to the, this is also a hybrid VAV ECMO. So difference here is you're having blood being drained from the femoral vein, oxygenated, CO2 removed, and then it's pumped back to the patient, but via the femoral artery, but also through the right IJV. Now, this solves the problem of having deoxygenated blood circulating to the brain. So you have oxygenated blood which is pumped back into the right the right ventricle and through the pulmonary circulation and the brain. Yeah, so that's the other modification. So we also look at the venopulmonary arterial ECMO. In this case, we have blood being drained from the either from the femoral artery, and remember, I think I've been talking about the femoral artery all the time, but you can also have from the right IJV. So in other words, blood draining from the SVC through the right IJV, oxygenated, CO2 removed, and pumped back. Now, in this case, this blood goes to the pulmonary trunk. So this bypasses the RV. So this this is very important in patients who, however, this can only be done definitely under fluoroscopy and echo. And so in cases where you have RV failure, this helps with bypassing that and blood going through the pulmonary circulation and then to the LV. Yeah, so this, but again, it requires, it's more, it cannot be done as a, an emergent procedure. The other, so we've also, so this extracorporeal CO2 removal is particularly indicated for patients with hypercapnic respiratory failure without hypoxemia. So because the whole point is we have CO2 removal and we have limited oxygenation. There are different modifications, but the ones I have here, you can see this, you have this is a dual lumen cannula, which is this drainage from the SBC. This blood is pumped through the artificial lung or where CO2 is removed. And remember, we just said there's limited oxygenation of this blood, and it's taken back through the IJV, back. So the issue in this case, these are low flow. This require it's ideally supposed to be low flow, and also we talked about the fact that if CO2 removal is rapid, we risk cerebral vasoconstriction and hemorrhage. So this is usually done quite slow. Of course, the downside to this is formation of microthrombi, and that could cause the membrane to that could affect the diffusibility through the membrane, but also, you have clots forming within the circuits. So the other modifications, so you have the low flow echo, and also so both these are supposed to be low flows for that reason, and so which means that on the other side you can actually have proper oxygenation because of the flows. The other modification is the arteriovenous extracorporeal removal. Now, these two configurations are actually, if you notice, there are no pumps within this. So the very first one, arteriovenous echo removal, uses the arterial system to pump the blood. So it's arterial. The blood is pumped from the artery. It is drained from the artery, goes through that artificial lung. CO2 is removed, and this blood is goes back to the patient. So there's actually no pump within that. So it's the arterial system that pumps through that artificial lung. And for this, the pumpless interventional lung assist, this one is important because we have blood coming from the arterial system, goes through the artificial lung. Sorry, we have blood coming from the pulmonary artery trunk, which is where CO2 is removed, and then it goes back to the left side. So this bypasses it bypasses the RV. So in patients with RV dysfunction, this is very important because you have blood that is just coming up just after the pulmonary, past the RV, so from the pulmonary trunk. So same thing. So there are complications of ECMO, and already gone through most of them: the intracranial hemorrhage or stroke. This could be one from the clots. When blood is returned to the artery, there can be clot formation, and you can end up with a stroke, especially in the retrograde blood flow ECMO, but also the issues of anticoagulation can risk hemorrhage. Hemolysis, because the blood goes through the circuits, so you expect that just like all the circuits where blood flows. Venous thromboembolism, talked about that. Major bleeding could be as a result of anticoagulation. the oxygenator failure, cannulation issues, other complications, we have leg ischemia, which we also talked about, sepsis, multi-organ failure. We can have, line sepsis mostly. So quite many complications. So just going through a few practicalities. So patients who are on ECMO ideally should still go on having their mechanical ventilation, be just their lung protective ventilation, because that will help with a bit of recruitment of our lungs, will keep the lungs open, and also it's a way of monitoring recovery of our lungs. So that keeps on, and also over time, you find that there is contribution of oxygenation and removal of CO2 from actually the lung itself. So that will help with the weaning off the ECMO. Oxygen thresholds while on ECMO, targets are between 88 to 93, not less, not more. CO2 thresholds, we're looking at pH above 7.25 to not more than 7.45. And for patients who are having ECMO and probably previously proned, most recommend that proning should not continue to happen, just because it's easy to decannulate patients who are being proned. So yeah, patients can be unproned during ECMO. Anticoagulation, so always, most times there's going to be anticoagulation required for patients who are on ECMO. There's so many other studies that we can look at, ECMO-free anticoagulation, but yeah, that's something to think about. And also when they're weaning off ECMO, the blood flows, I think the question is whether there's the blood flow through the circuit should be reduced fast, or the sweep gas flow rate reduced fast. Yeah, so the different, some it's the sweep gas flow, others it's the blood flow. Yeah. Then blood transfusion targets should be 7 to 8. Anything less, according to studies, increases mortality. There's also been increased mortality associated with patients who are on ECMO and RRT. Yeah, so that's this renal replacement therapy, something to look at. Cardiovascular monitoring during ECMO, it's shown that the dilution techniques have less accurate, the lithium and all. And so the echocardiographic studies actually it's shown that that's actually what does help a lot in the cardiovascular monitoring during ECMO. The temperature management, temperature should be kept between 33 to 34 for, when we look at the oxygen dissociation curve, this also reduces the basal metabolic rates and oxygen consumption. The drug interactions during ECMO, it's very important to keep reviewing the drug dosages, right from the start of ECMO, and to weaning off, because they will keep changing. But we think about the pharmacodynamics and pharmacokinetics. So those are my references. The other thing that probably I will ask you to go and look up are different conditions, ECMO, like ECMO in different conditions like asthma, cardiac arrest, and all those things. Yeah, look at those conditions and ECMO. Thank you.
Thank you very much, Dr. Claire. Yeah, surely quite a big topic here. And I guess we really needed to hear this because in Uganda, unfortunately, our interventions end at ventilation, and you really have to be a Jedi in, in ventilation to pull out some of these patients, because frequently reach a point where there is nothing more you can actually do. You can adjust the vent and they're just going into cardiorespiratory failure, multi-organ failure. And you know that maybe something else would have helped, but unfortunately you don't have the resources. So we know this exists out there. And there are even smaller devices, especially when it comes to obstructive airway disease, where the primary problem is CO2. Things like the I-lung, as Dr. Claire mentioned, extracorporeal means that you can just insert bedside. Unfortunately, we live in a shithole country where we may not be able to access some of these things readily, and hopefully some of us who love gadgets can, buy them ourselves, keep them in our pockets, and maybe use on some of the patients. Unfortunately, again, in the critical care area, and especially in our setting where smoking is not such a, yes, people smoke, but somehow, maybe because they're younger, the COPD population is not really extremely big, and they don't really present so much in ICU. And when they present in ICU, they seem to just turn around with just simple conventional ventilation. But there are people with, major issues with bronchospastic diseases. For example, in the West, there are people who smoke heroin or smoke other drugs, and these things can irritate the airways and lead to quite a terrible vasospasm, sorry, a bronchospasm, which may not break easily, and these guys die. So most of them end up on ECMO for a chance to survive. So this is really quite a good talk and has been quite informative. Thank you, Dr. Claire. And maybe for most of us, it's a wish. Personally, it's also a wish that I could have this, but it may take a while before we have them here. So it's key to still go back and master how to play with a ventilator, to just keep helping your patients, and hope that you never get one who doesn't improve on ventilation alone. So some questions, Dr. Claire, on the chat. Thank you very much, Dr. Barker. Do patients on ECMO continue to breathe? That's a question from Ignatius. Dr. Claire, do patients on ECMO continue to breathe?
Thank you for the question. Yeah, so ideally, we've just mentioned that patients on ECMO should still go on to have the mechanical ventilation, but with that, you can actually continue to do your lung protective ventilation because your ECMO is doing most of the work for you. So yes, and there are benefits because you have your lungs are being recruited and they're staying open. You have, it also helps with that. I don't know how to say, like, yeah, I mean, yeah, but so yeah, I think the question is, I think I've answered the question. Patients need to have the mechanical ventilation happening even when they're on ECMO.
Yeah, sure. So sure, definitely if they're in ventilation, especially for respiratory issues, most times people get ECMO to try to rest the lungs, and that means you can convert to ultra low tidal volume ventilation, reducing tidals to like 2 to 4 mils per kg ideal body weight, so that lungs rest and avoid ventilator-induced worsening of lung injury. Patients who on VA ECMO on hemodynamic support might even recover enough to be extubated and ambulate well on ECMO, because the ECMO machine meets their respiratory requirements as well as the hemodynamic requirements. And usually they do that even in respiratory situations. Patients who are in line for transplant, the general consensus globally has been to avoid intubating them, because once they intubated, there's a belief that they rapidly develop diaphragmatic and respiratory muscle weakness. And so when they go on transplant, the immunosuppressive therapies they get and the long route recovery, especially from lung transplant, means that they're likely to suffer severe, respiratory muscle weakness, and so it may delay recovery from ventilation. And this puts them at risk of recurrent infections in the lung and maybe failure to come off ventilation. So frequently, patients on transplant pathway are not intubated. They are instead put on ECMO, and they can walk around breathing like they have no problem. And these are usually elective patients. Certainly, it's harder when the patient has already been intubated, and frequently, at least for most of the services I know that do lung transplantation, they reject these patients. They don't accept to transplant them once they've been intubated. Dr. Gbaka, the other question is, can patients on ECMO receive volatile anesthetics in case they need surgery? Or do we have to just use TIVA in this situation? And what's the longest someone has survived on ECMO?
Thanks for the question. Dr. Kelo, I thought you laughed about it, so I don't know. Will you help me answer that question? I'm not too sure about...
Yeah. So the challenge is for patients who are going on ECMO, the idea is that the lungs are so bad that they may not be able to generate as much tidals safely to facilitate maybe adequate intake of volatile anesthetic. So you may have to supplement. Or provide anesthesia through the ECMO circuit if you are going to, the same way you are infusing the gas, the flow, that's the sweep gas, that's oxygen into the oxygenator. You can do the same with the volatile anesthetics onto the circuit. I've seen a few circuits of that kind. But the challenge is maintaining the anesthetic doses. That means that you need to monitor them very closely on the inflow and the outflow, just so that just the same way you do with the ventilator when you're doing provide anesthesia, inhaled anesthesia on a vent. But yes, in the end, TIVA has a role. So in these patients tend to get mixed, or they go exclusive on TIVA to be sure that they're getting the anesthetic. Regarding how long the patients have been on ECMO, I think it's quite a fun question because I've not thought about it. But when I looked up online, the longest I've seen seems to be about over 300 days, and this was a patient in Dubai, in Abu Dhabi. There are other reports, but they really conflict. Like there's a report of a patient who spent 551 days, but in truth, the patient spent about 45 days on ECMO, and then was transitioned to another extracorporeal device called the an LVAD to support them, actually intracorporeal device that helped them. So they completed 551 days on ECMO stroke VAD. Then others of 150 and so on, but the longest appears to be 300 something. Maybe we can keep looking at other numbers. But generally, in most places, ECMO is extremely expensive to run. Where I trained, a day on ECMO costed the hospital about $10,000 per day just for ECMO alone. That was minus the rest of the in-hospital care. And so most times ECMO is used as a bridge that is used for a short time, a bridge to decision, a bridge to transplant, a bridge to long-term therapies like maybe VADs or transplant, or it could be a destination therapy for someone who is going to recover. So it depends on the situation, and the selection criteria are extremely, extremely stringent in most countries. I imagine for Abu Dhabi, I mean, this is the oil capital. So, I mean, these guys can keep the patient on ECMO for all those days. But even good old Canada cannot keep a patient for too long because they need those ECMO machines for other patients. And so they choose the youngest patients with the high reversible problems that can easily be cured over a short period of time. So we may never really think about that duration in our setting here because it will be worse. And in a few days, we shall be discussing end-of-life care or transitioning to another therapy. What you should probably be thinking about is how long can you keep a patient on a ventilator, because that is the low-hanging fruit for us here. And we have quite a number of patients who have spent days to years on ventilators, especially being transitioned even to home care on ventilators. I'm not trying to say we cannot think about being extravagant with ECMO, but one day we shall have it here and maybe to win every compound. Thank you. Final question before we close, Dr. Barker. How do we minimize hemodynamic disturbance on a patient in ECMO? Dr. Barker?
Yeah. Did you say, how do we minimize hemodynamic
disturbance in patients on ECMO?
Patients on ECMO. I mean, I don't know in the first place why, I don't know, because ideally, if a patient just has hypoxemia or, hypercapnia, those two issues, and, they have good cardiac output, then, so the blood is going through circuits, and it's, if anything, if a patient had a pH less than 7.2, that would actually cause more hemodynamic issues, and which actually would tend to improve when the pH gets back to normal. But just like any other patient, if you have, if you require, vasopressors and all, the patient can still go on and have that while, in ECMO. In patients who have cardiogenic shock, and so the modality definitely is different. So it depends on what the indication is, and when it comes to cardiogenic shock, then the modality will be something that will actually support the heart and keep the hemodynamics stable. I don't know if I've answered your question.
Yeah, thank you. Maybe the other thing I could also add is that remember, this is an extracorporeal circuit, so patients sometimes get similar reactions they get when, like, you put them on they get some sort of anaphylactoid reactions, some similar to what they get when they are on dialysis circuits, and so they can occasionally develop a vasoplegic kind of picture. In the case of ECMO, that will present as what's called chatter, where they are sucking in blood to the circuit, but maybe because they're sucking in a larger volume of blood, there's rapid collapse of the walls of the venous system, resulting in the cannula sucking the walls and interrupting flow. So in that case, definitely good fluid resuscitation, just like you would do with any vasodilated patient who counts. Good, sometimes using pressors also helps in this situation. Be it venovenous or arterial ECMO. These guys are still at the same risk. And the other thing is that patients can bleed because of the anticoagulation, and frequently the bleeding tends to be retroperitoneal. So these patients might continue, notice a patient developing chatter, developing hypotension, going into shock while they're on ECMO, and keep wondering why it is. It's key to image these patients quite early because they're anticoagulated, and if they're bleeding retroperitoneal, it can be massive before you notice it. Sometimes a patient you put on venovenous ECMO to support respiration progressively develops circulatory failure from so many reasons, including just maybe even, let's say, thrombosis and developing pulmonary, pulmonary embolus, or it could be because of a myocardial infarct, or you underestimated disease initially. They came in and the primary presentation was hemodynamic, so there was respiratory, and then now they progressed to circulatory as well. In that case, converting the patient from VECMO to from VVECMO to VAECMO helps the hemodynamics, but then you have to continue supporting these patients. Then again, patients on VAECMO, what happens is that you're sucking blood from the venous circulation, oxygenating, and then returning to retrograde at a high pressure via the femoral artery, for example, and that blood is supposed to go all the way back to the aortic root where it will oxygenate the coronary circulation. Now, depending on the flow rates, your patient might end up with the poor perfusion of the coronaries with the heart failing because not being perfused, or they might end up with a very high pressure, which prevents the emptying of the little blood. Remember, in ECMO, you don't arrest all blood flow through the heart. Some blood will still make its way through the pulmonary circulation. Some of it will go into the left circulation after going through the lungs, and it must be pumped out of the left ventricle. So if the head of retrograde flow is so highly pressurized, it can fill the left ventricle from emptying, and you end up with the swelling of the left ventricle, pulmonary edema, and such things. So you may need to do what they call ventilation of the left ventricle, something called an LV vent, and also modifying so quite a lot of things, and this is quite a can of worms we're opening, and I don't think we shall complete the topic today. The idea was to inspire you, to stimulate you, and help you think about therapies that we may not be able to have here, that you could have one day if you got exposed somewhere, or if you got rich, and you could buy and keep in your house. I'd like to bring this to a conclusion very soon. But before we do that, I would like to invite the mentor of the day to leave us with a few words of wisdom that he might have shared in secret with his team, and they may not have brought it out nicely here, or that they have brought already, but he wants to emphasize. So Dr. Peter Agaba, kindly, just a few words before we conclude. Thank you.
Thank you, Erasmus. I don't have any secrets to impart. I think the guys did a good job. Maybe as a parting comment, that I think at the end of the day, for most of these types of patients, you want to understand the pathophysiology of the disease, and that allows you to adjust your treatment accordingly. There are all these guides and rules out there, but you still will need to listen to your patient. The simple things are the medical part and the evidence for that. The difficult part is fine-tuning the respiratory support for the patient. I don't have anything wise to say beyond that.
All right, thank you very much, Dr. Agaba, and thank you for mentoring the team and guiding them. So we've gone way past our time, and the goal is always to stop at 7 p.m., but we'll try harder next time and hopefully start early. Time really, not even earlier. So today has been a conversation on obstructive airways disease. And as I keep saying, we are laying the foundation for some other deeper conversation we're going to have in future, just to help us appreciate the physiology and the physiological changes that patients come with. And this has been well handled by the team. I guess for me, the summary of things that we need to just remember always with this is hypercapnia and ventilatory failure, the hallmarks of obstructive airway physiology. And in this case, the airway can obstruct from anywhere and ends up messing up with CO2 removal and ventilation function, and ultimately the patient can deteriorate, develop right ventricular failure and the like. So it's really key to manage these patients, in a timely manner, but also very carefully. Some of the therapies that we are used to doing, we like to pull out our laryngoscope and intubate, we like to put them on a ventilator. These are things that we have to be extremely cautious about, because you are screwed if you do, and you are screwed if you don't sometimes. And so you have to find that middle ground and find a way to play your therapy safely. Auto PEEP, as we are taught to measure and as the ventilators measure, is not always going to reflect the total auto PEEP in the patient, because not all the airways are actually communicating with the main airways from which the measurement of PEEP is happening. As such, take auto PEEP that you measure as just a fraction of the total auto PEEP in the patient, and always be cautious. That's why I was saying at the beginning that some of the patients we win from the ventilator actually, and then we are sending out of the ICU, actually go out when they still have pulsus paradoxus, meaning that they still auto-peeping in them or air trapping. And hopefully it will get better with the time. That's why most of them don't come back. Or they might end up with another doctor that they trust better than us. So just be mindful about that. But as much as possible for these patients, let's maximize our knowledge, experience, and practice of the use of NIV and high flow nasal cannulas to prevent intubation, because even in the best hands, an intubated obstructed patient is quite a deadly one to manage. Thank you so much for today. And we meet again on Friday when we shall be dealing with patients who are coughing up blood clots. That's quite a fun one. And we have quite a star team again to handle it. So for tonight, I wish you a great night and a great weekend until we meet again. Thank you very much and goodbye. Good night, everyone.
Good night.